So I'm going to go ahead and get started. And I may have to stop and let somebody in, but we'll get rolling here. So thanks for coming today. And we're having our QMP meeting on COVID this part of the month. Later in the month, we'll go back to regular QMP and talk about the next elements we're working on. I also have decided that I'll rerun the whole quality project again, starting in June, all the way June, July, August, and September, and run the same one over again to help people from requests that I've got. So I thought I was done talking about COVID. I thought we had it. And much to my surprise, more things came. So let's talk about some of the good news. On the state level, the assisted living industry has had a very high success of getting residents vaccinated. We're really shining in the general perspective, and so we're really good. And all we have to do now is just watch for our new residents, because some of them, especially, have come from other places, and you may not be able to match up lots for them. So it'll be interesting to work through that as we go. Some people have had a really rough dose 2. I had no idea how rough dose 2s could be until I did it myself, and it knocked me on my booty. Long hauler syndromes are a lot more understood than they were even a month ago. So we now know the brain fog complaints, the inability to retain information, the lack of smell, the lack of taste, the weird fatigue that comes out of nowhere. So people might be feeling a whole lot better, and then 2 or 3 weeks later, they feel like crap again. This is all what we call long hauler syndromes. And they're especially interested in the senior market to see what it's going to look like, because they already know that the kid market and the young adult market's looking different than the middle-aged and the young senior market. For our industry, we're going to stick with Pfizer and Moderna. They did pull J&J out of the long-term care market and decided that we needed the stronger one. And there's a good reason. There is a variant on the loose. You've heard about it. It's in India. There's another variant on the loose in Brazil. And if either of those make their way over here, we're going to have another surge, and it'll be a toughie. Colorado's opening up and looking a lot better, a lot stronger. Looks like people are kind of tired as COVID as I am and just want to get their lives back. And then for your staff, vaccination centers are open, no appointment needed. All they got to do is drive and get themselves over there and get the shots. If they want J&J, they are going to need to go to Walgreens, CVS at Target, Safeway, King Soopers. But Walgreens got a lot of money up front, so they've added staff to give shots without an appointment. And so that has really opened the doors in the last few days. Some super good news, which really made me happy. All residents that are fully vaccinated can return to normal dining and activities. So they can sit together in the little houses. If you have a big place and you have congregate cohort groups, please continue that right now. But the residents can have their life back. Staff have to wear a full mask, and that over the nose, over the mouth, not under the chin, not up on the head as a Band-Aid, but full mask. And they still have to wear surgical masks. Now, yesterday there was a whole lot of noise about N95s. And so when I do an update later this month, I'm going to try to get more clarity, because N95s, 1, are super expensive. 2, they have to be fitted. 3, they have to have a valve. And 4, they require a very specific cleaning methodology. To me, it makes no sense in our industry. So unless we have a COVID wing, if you have a facility that you've contracted to Colorado to be a COVID wing, if we have another outbreak, that's the only place they make sense. So I'm trying to get some clarity on that tomorrow, and I will let everybody know as soon as I get a better picture on it. All right, some not so good news. We're still having a very low staff actually getting their vaccines. And I'm not sure where we're going with this legally, because we have a major flu vaccine mandate, and you have to have 90% of people, 90% of the people have to had the flu vaccine or have a medical release on letterhead, not a I just don't want to. Our religious views that got plopped out a few years ago. So I'm really concerned about staph resistance. And I'm even more concerned because of the bad reaction I had to the second shot. I get it. So that's why I think J&J's decent enough for the majority of our staff that have been very scared about getting any RNAs. So the courts are caught up in a lot of the conflict. It's actually in court in 3 states right now on whether companies can mandate the vaccine to get people back to work. You probably have heard in the news that companies, governments, they want their people back in their offices, and most of them are actually starting next Monday in Colorado. And this ought to be interesting to see what happens on that story. Families and visitors do not have to show proof, though what I have heard and from a lot of administrators, families have been very positive in actually wanting to protect their loved ones. So I'm not hearing that there's major meltdowns or temper tantrums about being vaccinated. As I said before, we have 2 new variants. The one I'm mostly worried about right now is the Brazilian one. And then I'm praying to God that the mess that's over in Europe and East Africa or Middle East doesn't come this direction. Israel was down for 14 days. They literally shut the country down, and the people didn't tolerate it very well. I don't think that our country would tolerate being on an 100% shutdown again. So we have new outbreaks. The interesting part about it is that even though we're having some increase in positive testing, we're not having a major in hospitalization rate. So the medical staff have figured out how to treat this outpatient for a great deal of people, and including our seniors, where a lot of seniors who have come up with COVID in the last 30 days or so are not being hospitalized and doing quite well treating this at home. The state decided not to renew their contracts for our industry, but I think if we have another outbreak and we have a need, we might be able to get that put back in order. Okay, so let's review the notebook. This is super essential. I've been helping facilities get this thing together, and did have a company have a survey last week that had it together. They got very positive feedback because they had it together, and they had no tags. Even though there was a few things not working quite right, they got 999s, but not a tag. So it has 5 parts. And one of the first things you need is an accurate census list and staff roster. Should be 2 separate papers. I have tools that I've built and changed them up because there are things that surveyors need, like dates of vaccines, that type of thing that is very important to them. And so if you want to have really good relationship with the surveyor coming in and you do this new census sheet, it'll make your life a lot better. So please remember that OSHA or anybody in the county can come in, the fire department can come in and ask for this list. Same thing on staff roster. The reason that this list is so important is what they're doing contract tracing. So if one of your staff people show up positive and they're out sick with real symptoms, they will actually contact all your other staff and test them just to see if it processed within their circle of influence. So it's very interesting how they're doing this contract tracing. They tried to put an app on people's phones. They had very few uptakes in it in the older adult markets, a little bit in the kids markets because they love apps. And they don't mind if the state's in their phone and in their business. So like I said, this whole contract tracing is going to be very interesting. All right, so part 2, you need a calendar. And the reason you need the calendar is for your sanity. So if one, you want to mark each week the test date that you do your test. And then when it comes back, if you have nothing, just put R equals 0. Results, nobody was positive. If you have a positive, then and as a resident, then you need to count 90 days forward, put that resident's name on your calendar, and you retest them at the 90-day marker. If it's a staff person and they're not vaccinated, then they're off for 14 days. You do not have to pay them. That was changed after a major fury across the country to the feds about paying people just because they claim to be positive. So especially if they're not vaccinated. Now, if they're vaccinated, there's a guideline for what to do. They can work in a COVID area, and they may or may not be able to come back to work. And there's a 10-day rule and a 14-day rule. So instead of trying to spell that out, if you get in that situation, you're going to need to open up your map and just figure out where you are. And you won't retain it anyway until you need it. So again, this is another reason we want to get our staff vaccinated, is because then if they're off sick, they fall under regular sick protocols, and then there is different rules. But if they refuse to vaccinate, then it's on their dime. And then anything else on the calendar that you want to mark, if you bring PPE and if you want to track it there, even though you're doing an EM resource, anything else that'll make your life easier, but at least do these things on your calendar. Very important to keep your sanity together. It's very hard to remember. I can't even remember what I did Monday, not alone, 3 weeks ago. All right, so the data tools that are coming. So when you're getting data tools, it is important that you have that information and that you keep it, but do not keep it in a open area. So do not put it in your notebook. It needs to be in a locked folder file that nobody else has access to, and keep that data sheets, because you need to keep them for 3 years. And so that you have proof in the pudding. So again, when surveyors come in, they look at your notebook, you'll pull your data sheets out, they can look and see that you're doing due diligence, they see your calendar, they see you're doing due diligence, and you've got 3 major bases covered. Now, if you're having trouble with Mako data, I had a long conversation with them last week. I finally understand Pluto a little better than I was understanding it. And so contact me and I'll put you in contact with the young man I worked with, and maybe we can resolve the issue. I also suggest that you buy a thumb drive, and you need it for a lot of things, but this thumb drive is business related, and you can put all your data sheets onto that thumb drive as a backup. So after 30 days, you can archive your hard copies, and then you have them on the thumb drive if you need them. But you need to have a backup system, either in the cloud or on a thumb drive. Somehow or another, you need a backup. Okay. And then your sign-in sheets, same thing. Those you can get stacks. So what I recommend is have the night shift at the end of every month. Scan them all into your thumb drive in a file, and then you can shred the hard copies after the next 30 days, and you've got a backup file, you've got the current 30 days, and you have to keep those records for 3 years. You can have a couple of miles of paper if you don't find a methodology to do this better. All right, any questions about data? Data is might be newer to a lot of you. All right. Now, part 3 is your training. So training is important. Please don't forget your own. So take the basic training sheet. A lot of you have the template I made. And you just put, in the ALR COVID trainings, in the date, and you attended my class, and you sign it, and it's showing that you're attending. You go to the infection control meetings, anything that you do, please take credit for your own work. On the staff side, what I've been encouraging heavily is make them topic driven. So if you are doing basic infection control, or you're doing hand washing, or you're doing putting on gloves, or you're doing how to wear a mask for safety, how do you enter or exit a sick room, any of those training topics you're doing, if you will do the training topic and then where to locate it, whether you're doing CDC or the health department or a Relias project or anybody else's trainings, then you put it where it's located, how to get to it, the date, and the staff sign it, it's their signature, and then the date. And then what I tell the staff is when you sign something, it's a contract. That means you're responsible for this information. And if you don't get it, let me know, and I'll find some other trainings to help you get it better, because we want you to feel comfortable with this. And so I don't want to hear from industries when staff say we were never trained on this. Because again, when the staff say that and the surveyor says, well, they said they were never trained, you say, excuse me, here's our training book, here's all the topics, here's the dates they took the classes, here's the site that they took the classes from. And then the surveyors have to back down. But they've been writing tags like crazy people about this whole thing about training topics. Well, the other thing I want to encourage you is have a master sheet of signatures. You need that in 3 places in reality. You need it here in your COVID book. You need it in your MARS forms. So you need to have a master sheet, an electronic signature, and a real signature for if you're doing electronic MARS. And then you should have a master sheet in case you have to evacuate and you need to validate if somebody is in your group or not. So if you had an evacuation, you give somebody authority to use your credit card for this emergency basis, you have an electronic signature to make sure that it didn't get ripped off. So I would encourage you to use your master sheet in those 3 places at least. All right, so part 4 is all your internal policies. Now remember, the state's made a wonderful book for us. You all should have that, and that'll be in the next section. But you need some internal policies. They do not have to be written legalese or gold standard. Actually, the simpler the English, the better. So what we like to have is, let's say, indoor policies. Okay, if residents may have indoor policies from 8 a.m. to 9 p.m. Visitor will call, make an appointment, will sign in and pass the screening process, will wash, will wear a mask, may visit in the room or may visit in a community room for the time period agreed upon. If they want to have a quick hug or have a quick kiss and hug, they must wash their hands and wash their face after that. They have it. And please do not sit and hold hands for 45 minutes. So one of the things I've been thinking about for a couple of weeks here is we need to have little 5x7 postcards, how to have a successful visit. Because we're again asking families and visitors to, go to gold standards, but we're not telling them what those gold standards are. All of your outdoor policies, now they may be a little lighter. So yes, they can bring lunch and they can sit in one of the designated areas and have lunch together. When they're not eating, please put their mask back on. Residents don't have to wear a mask unless they choose to. Now, they should probably wear a mask when they're out in the main community to keep from bringing anything else home that's out there. But again, if your community, rural community especially, says no more masks are needed outdoors, but social distancing is encouraged, you have to gauge that. But I'll tell you, for just sanity's sakes, if you can get your residents to wear a mask when they're outdoors, or going out to visits to church or to families' homes, barbecues, it's safer for everybody if they will do that. Some of the other trainings that you should have in your internal policies is your training and competency policy and how you want people to do it and the tools they can use, approved tools that you can accept for training. Resident family communication, any communications you send out to families, any resident communication, if you have a resident meeting, a resident huddle, make sure you're tracking all that. Your sign-in program, what does it look like? How does the temperature get taken? Are you doing oxygen checks at your facility? Whatever you're doing, the sign-in log, just again, simple English, simple process. Your testing policies and your checklists, so that you're testing with Mako weekly. If you have an outbreak, you will follow CDC guidelines and state health department guidelines for increasing your test rate. And then you might be testing every 3 days. You may have residents in quarantine. That one, you can use the map and you don't even have to invent it. You just need to put it over here so you can get to it really quick. You need to make sure all your doctors are up to date. They need to know what vaccine their residents got and the lot number and what the date. So make sure that you've got a copy of those cards and give it to the doctors so they can put in their medical records. And then anything with Mako. So that's just some of the policies that I think are pretty common that you need, internal policies. And again, simple, very simple, how to, doable, not hard to follow, and you're not driving yourself over the wall with pie in the sky. I like the simpler the better. And then part 5 is anything that the state or the feds put out. So this is the list of the things that need to be in COVID itself. So on the Public Health Order 2020, we had version 6. Version 7 just came out and it was extended to July of 2021. Polis said the other day he will be expanding it through September, and then they'll decide whether or not it can be lightened up, depending if we can get through the summer without any surges. So all you got to do is in the current one, just mark the date and say extended to 7/2021. You don't have to reprint it. You should have the residential care facility guideline booklet. If you don't, I have it, and you're welcome to let me know and I'll give it to you. And in there, what I've done with mine is I put it in a notebook. I use little yellow stickies on areas that are important to me that I need to find real quickly. And I use my yellow highlighter to go through and mark the things that are really up there in importance. And then your infection control. So Stacy went to a class with the health over at CMS, got a certificate for training. She has those big high guidelines. The state has guidelines both at the ground level and in chapter 7, some indications of where they are. But you want to concentrate on COVID guidelines, and then regular infection control goes in your other policy book. EPA guidelines, this is because you can't use things from the dollar store and other things if they're not on the EPA list for cleaning, for disinfectant, for air management, ventilation management. They're not sanctioned. So make sure that anything you're using is in that EPA list. And what I do is I just keep that stupid EPA thing on my desktop so I can go look at it if I need to. I'm not a big person in chemicals. I frankly don't use chemicals at my house, but it's a facility, so you have to do a little more than green. And then all your PPE guidelines, some great guidelines, some great training tools for putting on, putting off mask, gloves, gown. How do you do the trash inside the room if you have a positive isolation case? How do you do the trash outside the room if you have somebody in quarantine? Quarantine signs, infection control signs, hand washing signs, isolation signage. Make sure that if you got anybody in any of those quarantine or isolation, that their room is highly marked, just like you would if you had somebody on oxygen. Oxygen in use, no smoking, that's a mandated sign, okay? And then over time, I hope over the summer that you will find time to crosswalk your normal policy book to your COVID. And again, it's mostly for you to know if a surveyor or OSHA comes in the house to say, yes, these are our policies, this is how we use it, this is what we're doing. And so you can walk and talk smart, and so that they can't trip you up. Okay, so again, the public health orders extended through July. So mark your front page extended, and that'll take care of you. And then right now, what we're trying to achieve and what they talked about yesterday in infection control is this herd immunity issue. So again, we're doing incredibly well on the resident side. We're sucking air on the staff side. So one of our collective jobs is we've got to convince the staff that if we can get everybody fully vaccinated, we get out of the mask business. And we're not going to get there till we get to fully vaccination levels. And they said yesterday that looks at minimum at 80%. Okay, so variants. Sad to say we got 2 of them. And one is from Brazil, and it caused huge havoc down there, high death rates, high hospitalizations. They ran out of everything. And so other countries were getting stuff shipped to them. Now we're seeing it in India, and they're out of everything. They don't have beds, high death rates, 4,000 cases a day or better. It's raised total havoc in India. And neither variants would be very good if they got here in full. So I'm praying we can keep them out of the country, and the things that they're doing, especially international travel, makes a difference. one of the things that's really interesting about both of them is variants are like humans. So if you look around, even in this group, we're all different. We have different sizes, different skin tones, different genetic compositions, different nationalities. Well, variants are the same thing. They're going to do the survival of the fittest, and they're working really hard to survive. They don't want to be stamped out. And so so we've seen this in many other kinds of epidemics that we've had. Pandemics are when it affects the whole world. Epidemics is when it affects a region. So one of the epidemics a few years ago that got our attention was Ebola, and it was kicking butt in East Africa. And it was taking them out because they really didn't know how to treat. Well, believe it or not, they actually set the stage for a lot of the measures we use right now because they worked. And then they were able to quench it down, and then they were able to stamp it out, and now they are trying to vaccinate all of their people so it don't come back. And Ebola is very similar to what we got here in the SARS viruses, where it wanted to take a hold and it did not want to be removed. So this is our new variant, and I've been showing variants on a monthly basis because they fascinate me. And so we had the spikes, the early variant, the red ones, had a little yellow thing that would poke out among a triangle set of spikes and attach itself to a cell, and then put the bad genes into the good cell and take them over, and it would just spread like a fire hose. Well, the variant said, hey, you're trying to get rid of us, so we're going to do something different. So they developed what we call horns. And the horns were very, if you can see here where my mouse is, this is kind of a horn where it has a little dip in it, and they're suction cups. And so they could suck themselves onto good cells, and then they pour the bad crap into the good cells, and it would spread really fast, and they could take over thousands and thousands of cells in a really short period of time, like hours. Well, then we were stamping that out. Then the variant said, well, you don't like that? What else can we do? Well, now they've made what they call, these are big suction cups. So you see this little white thing in here. And over here, this is a mature suction cup. These are babies. They grow rapidly. This is blood supply. All that white stuff you see is their personal blood supply. And then the brain is in the center. And these suction cups, when they attach to cells, they literally stay there. They don't come back off, so they don't get exploded. The people that are vaccinated, the suction cups can't attach to the good cells because the body is already coding, and it happens every 14 days. You have a full blood supply turnover every 14 days, the normal human being does. So this vaccine that we've done has stimulated our body to build the product so that these stupid things can't attach to your good cells and take you over. I'm hoping that they are right on target, and that this thing can't find another tool to rebuild itself, and that they've got it right with the 3 vaccines that we have on the market. So what have we accomplished? Well, some pretty good stuff. So we have accomplished that we're in phase 2 of the vaccination program. We don't have to have appointments anymore. And most of the facilities have gotten information from their drug suppliers, like their contracts, or CVS, Walgreens, if you need vaccines for new residents, how to get that accomplished. We have 1,300 contracts. They've really went way overboard. Most states are less than 10. So we have 1,300 available to serve the whole state. Right now, as of last Friday, we had 2.4 million Colorados have had 1 shot, 1.5 are fully immunized, and our vaccines is 3.6 total. It's a pretty good accomplishment, but we're still low. So we have about 5 million adults in the state, 25% of them are over 50. Remember that we're one of the fastest aging states in the country. By 2030, we could take over and be the #1 aging state. All depends on some factors, but everybody worries about it. So the campaign that we see is to be the top state is a focus. We were 15 at the end of April at 82% efficiency. New Hampshire was #1 at 89. And Colorado's put a ton of money into this. I have been talking to other states and talking to administrators in other states, and they get very little and we get a lot. So we're almost on overload, in my opinion. but we have other states getting as little, very, very little, and they're feeling like they're on their own, and they just got to make it work. And all they have contact with is the CDC. So in some ways, I think that we are super blessed that we have agency that cares, and we have epidemiologists that care, even though they talk over our heads a great deal. And we have people in the governor's office that really care and have been a great voice and to continue this conversation and to keep it moving. So just as a reminder, Pfizer and Moderna remain a two-step program, and those are the total numbers on each product that were given by the end of April. And Johnson & Johnson is the one step, and that was the number given by the end of April. So we got some more guidances. As I said, I have the guidebook if you don't own it already. It was sent out in the portal on the 19th of April. It's really easy to use. I was very impressed. I actually contacted the man that wrote it and said, thank you, God, for making it simple, simple English and doable. And so he did some really good stuff. When you put the electronic copy on your desktop, you can do like if you've taken our classes, that Control F for search box, and you can put a keyword in and it'll take you all the sections that have that keyword. So let's go through some of the topics that are important that we're still wrapping our arms around. So testing, all new residents are in testing for at least 3 cycles, regardless of vaccination status. So I don't care if they're fully vaccinated, they are tested at least 3 times. Then you can figure out whether or not you can take them off. Any resident goes out in the community for events, family visits, barbecues, vacations, they're in testing cycle. All right, if you have an outbreak, okay, all residents and all staff are tested at least twice, and it may be longer. It all depends on results. So if you have an outbreak and you hit that map and you have this outbreak and you match, then indoor visits are closed. Then you also have to contact your public health department, and testing will be guided by them. The state disseminated or realigned their work back to the counties and asked the counties to help, because we have about 700 facilities in assisted living. I'm going to guess around 50 nursing homes. And, it's a lot of work. So they're trying to break up the work into smaller parts. And so the local health departments have been to a lot of trainings. And I had one local health department say, oh, we don't know anything what you're talking about. So I called the state and they contacted them. And the person that answered the phone got to go to education or something, because we haven't heard about that anymore. Remember that compassionate visits are all anytime. So if you have somebody on hospice, you should be in a private room, and anybody can visit at any time with PPE. And they have to get a call, make an appointment, let them know you're coming over. In hospice cases, when people are really, really sick, use gown, mask, and gloves, okay? And no touching. And so that made me very sad. There was a story on the news about a lady wasn't allowed a compassionate visit at the facility. And that was the very early of the outbreak. It had nothing to do with where we are. So it really agitated me that the news gave false information. And I have challenged them to update and get the facts out there instead of the drama. And so I'm going to be contacting them again now that I'm feeling better, finding out when they're running the correct story. Communal activities. Forget this, if your residents are, this is outbreak, I'm sorry. If we have an outbreak, communal activities stop and you go back to social distancing. A lot of people probably will end up eating in their rooms again, and activities are back in the hall and in the doorways and the stuff that we were doing early on. So if we can keep from outbreak status, hip, hip, hooray. All right, so one person is not an outbreak status, okay? They're looking for 2 or more. And it can be too probable with residents or staff. Now, one of the things we were fighting is that we were getting, especially with curative, that we were getting these positives, and then we would test them at the state lab or a private lab, and they were negative within 24 hours. We knew those tests were baloney. And the state kept saying, oh, no, they're accurate. No, impossible. You can't be COVID one day and not the next. So they finally relented on that. So they are, they may call you and ask for different testing or rapid testing on a daily basis. So again, follow the instructions, whatever you're told. The outbreak protocols are pretty black and white. It's pretty decent, okay? And then right now, in the week of April 21st, we had 21 of our facilities had new outbreaks, impacted 40 residents and 24 staff. So guys, this thing isn't totally over, so don't get too happy. But if you stay due diligence and you do these things, these are very basic things, I think you can stay out of this outbreak. All right, so some updates and symptoms. COVID comes on with severe chills, and they are down to the bone chills. You just literally, your whole body hurts all the way to the bone. You may have a cough with shortness of breath. That's the most common one I hear, is a severe shortness of breath. Bad muscle aches, and I don't mean just mild muscles like you sat too long or you just worked out and those muscles hadn't been used in a long time. I mean really down deep aching. Early symptom is that what they complain about, nothing tastes good and nothing smells good. That's been one of the most common. And even in our facilities that had outbreaks even a year ago, taste and smell may not be totally back. So it's been kind of interesting that it's not only an acute issue, but a long hauler complaint. Upper respiratory, where they can't lay flat, they have to either sleep up in a reclining chair or on 2 pillows or beds elevated. They just cannot handle the flatness. And they don't do, and we were trying in the hospitals, they were putting people on a BiPAP. It's a machine that forces air in your nose and putting them on their sides. Some people, they're still useful. It's not for everybody, but that has helped putting people on their side for ease of breathing. But what's more interesting to me is in the last month, in the outbreaks, they're also seeing diarrhea, nausea, and vomiting. Now, we normally associate that disaster with C. diff and norovirus, but yet the testing was negative on those cases where they were showing up with this explosive diarrhea. So pay attention. You may have to deal with this. And make sure that whoever is doing the cleanup in these rooms, that they are in double protection all the way. Because it spread rapidly. Remember, this goes through the nose, goes through the mouth. So you want double mask. You want a not only a yellow disposable gown, but I would recommend taking a black, very thick industrial trash bag and cutting that baby in half and slipping that over the yellow gown for additional protection, taping it to the back, and then double gloving and removing all of that inside the room into a throwaway bag that goes into another bag that's marked with one of those red tags that you should have in your fire and safety kit for hazardous waste. So when you're doing this, please be if you do to get this diarrhea stuff, take this stuff super seriously. All right, so let's revisit some of the core guidelines for infection control. We screen like crazy. We don't let our guard down. We use really good hand hygiene, follow all the best practices. And if you've taken my infection class, remember the best hand washing method is 2 times wash, 2 times rinse and dry, and then really dry well, especially between the fingers, and then glove management on dry hands, not wet hands, otherwise you'll get funguses, and changing gloves frequently. And so the state is not going to give out PPE, at least what they said yesterday, unless we have another outbreak. They do have some in stock, but they're not going to be supplying. So one of the things they're looking on EM Resource, when you say you have 7 days or 14 days worth, they're holding you to your word. So if you put on their EM Resource, you have enough PPE for 14 days, and then 3 days later, you call them and say, do you know where I can get gloves and masks? You're going to get questioned. So make sure that your EM Resource and the reality match, okay? Don't let your staff not to stop wearing their mask appropriately. Not around their chin, not off their nose, over their mask. Make sure they're wearing their mask. And when they use a surgical mask, it's for that shift, or maybe even a part of a shift, because if it gets dirty or wet, they need to change it. because again, we don't want mold and funguses growing around. So that's important. If they go out to smoke, that mask goes in the trash and they put a new one on. So if you have staff or residents that smoke anytime else, please make sure that that you're changing the mask enough, okay? And then test and respond. So again, the COVID notebook, keeping track of Mako, file it, scan it, put it in the cloud, have it handy. You got a 3-year requirement of keeping all of your testing, all of your sign-in screening sheets. Make sure that you've got a backup. And if you're really organized, you'll make the state happy. You'll certainly make OSHA happy, and it'll decrease some of your stress if you get one of those visits. Now, guys, the other thing I want to remind you, they're starting to show up at 7, 8, 9 o'clock at night in facilities. So you better have an action plan of the staff may need to call you quickly. Again, this is another reason to be organized, because they're not just making daytime visits. And then anybody that's sick is isolated or quarantined based off of what's going on in their life. If they have a positive COVID, then they are back in isolation for 14 days or unless the state releases them because they're fully vaccinated. So we're just going to have to play this out and take each case individually, follow the mapping guideline, talk to the state, and then document who you talk to, when you talk to, ask them to send you an email. And again, it's that circle of competency. So they say, oh, you can do this, this, and this. And will you say, please send me to me an email. I want to put it in our records. And then, then you've got proof in the pudding that you heard correctly and that this is what they told you. Okay. All right, so the new word for mask is called source control. I want to remind you that source control is not gaiters. It is not any of the cloth masks that we had to use in the beginning because we didn't have any. And yet they keep talking about N95s. As I said before, I'm going to try to get some more clarity because they were talking about them again yesterday, but they're super expensive. They're hard to maintain. They have to be fitted. And I want to make sure that we only have to wear these if we're in an outbreak. So the hospital systems have it kind of down, but we're not as astute and we're not skilled care. And that's my other argument. So I will let people know more conversation about the N95s as soon as I have a little more clarity, other than if you're in an isolation outbreak or a quarantine outbreak or the whole house is down. So the only thing I can say to you right now is at least get one box of them. I think there's 8 or 12 in a box. Put them away for an outbreak. So at least you have something to start with just in case. All right, so let's review quarantine, okay? So 14 days is a must, okay? New admissions that are fully vaccinated and have a 2-week post date. So you got to see the card, you copy the card, you put it in their medical record. Those are considered fully quarantined. If they don't have that card, they're not considered fully quarantined, then they have 14 days on admission to your facility. It's not good for marketing. So hopefully people have their cards. And be careful, make sure that their cards have their name on it. We have seen fraud cards going out all over the place, and young people are selling them to other people and putting those people's names on them, and they weren't the ones that got the shots. So again, another scam, that already is perpetuated out there, okay? We do want them, at least for the first week or so, to wear their mask in common areas on the grounds. We just want to, make sure that everything's cool and they get through one of our COVID tests, and then you can pull the mask inside. But remember, the terminology is fully vaccinated. Again, this is an internal policy that should be in part 4 of your book. What is a definition of fully vaccinated? And then you've taught it in your training. So you have a topic in your training tools. And what's fully vaccinated, everybody gets the terminology, they understand it, they sign the sheet, they're held responsible, and then you've done full circle. And so this will give you a great process to make sure you've got all of your T's crossed and all your I's dotted. Same thing with isolation. On page 14 to page 16, in the new guide, it talks all about isolation. So anybody that turns positive, vaccinated staff that turn positive, we're going to have to be very diligent, very careful until we get a better clarity whether this virus from either East Europe or South America gets its way over here. And then the one from India is the more scarier one. And then the antigens, as I showed you on the horns, and like I said, the body puts up this covering and the horns can't attach to it. So it has nothing to get a hold of and it just dies off, because once a horn goes out, that horn's not useful anymore. And they can't grow a new horn yet in that same space. So like I said, those crazy cells, they're trying like crazy to maintain a life and not get killed out. And so we just can only pray that we're smarter than they are. Your testing cycles will increase. The health department will help you. All you got to do is reach out. You don't have to do it on your own. Please don't do it on your own. The more you do in a collaboration, the more you show that you're actually doing due diligence. Okay. So do you quarantine or do you isolate? Okay. So for both, their room is, going to be hanging out at. The bathroom has to be cleaned after each use if it's shared, okay? If they have their own bathroom, it has to be cleaned daily. If they're having any loose stools or urinary incontinence, the toilet has to be cleaned after each use. So again, this is a high place where your staff can get sick. So make sure they're using the appropriate cleaning products and the appropriate cleaning wear to clean bathrooms. They should only have a person assigned to them out of the staff. And so that may take some coordination. And the staff would also manage the PPE and the waste disposal at the door. So a good protocol about how you're going to handle that. There's tremendous great videos. There are a lot of good tools out there. And so if you need reviews, use them. There's no harm in reviewing this a lot. This is still really new. Not as bad as a year ago, but it's still really new. All right, refusal, okay? We know that people are refusing the second vaccine. Frankly, after what I went through the last 36 hours, I get it. And I wish they'd just be more transparent. If you have these symptoms, here's how to handle it. It should have been easier. We have people that don't want to be tested. We have people that don't want to be vaccinated at all. And we have all this is my right, I had the right, I had the right, you can't violate my rights, I had the right. And I don't know where we're going and what the policy is going to look like in 6 months. But you have the right and the responsibility to evaluate this on risk management. So you may have residents that leave because they don't want to follow the risk management rules and being appropriate and doing the right thing when we have to. Can we all get through this together? You also, with your insurance, need to have, if you have your notebook together, because the insurance companies are asking for your COVID policies and your isolation policy, they're evaluating what your insurance is going to look like for 22 already. And then, like I said, if you have an outbreak and the staff refuses a test and non-vaccinated, they are off without pay for 14 days. And then you're out of the outbreak mode potentially at that point. And again, following that map will help you know whether you're in or out of it based off of all these different crazy factors we've been talking about. Okay. So partial vaccinations, that is not being fully vaccinated. The only one-step vaccination is Johnson & Johnson. So again, it's that 14 days. From the day of the shot, 14 days out, they're only partially vaccinated. You could have somebody, especially in staff, that are super spreaders. The agencies I work about that have staff that work in multiple facilities, that's the ones that I've been very worried about. And we have found some staff being super spreaders in different parts of the states. So please be very careful with anybody partially vaccinated, refusing to vaccinated, hold high standards, don't take shortcuts. And then be very generous with your compassionate visits. You don't want anybody, any news agency filming outside your building that you refused a compassionate visit. You are protected under regulations, and you cannot be sued if a visitor gets COVID or claims to get COVID, because it's not going to come from your facility, because you're going to escort them to the room and they can only stay in the room for the time period. You're going to set your watch, you're going to go back and get them, and you're going to escort them out after they wash their hands and face. And they take off their gloves and their gown, and they take it off in the room. So compassionate visit policy should be very defined, very systematic. All right, so again, just reviewing some things that the surveyors have been really looking at and fussing about: indoor visit guidelines, outdoor visit guidelines, compassionate visit guidelines. Ombudsmen and surveyors can come in. They do not have to show proof in the pudding they're vaccinated. I don't agree with it, but that's where we are. They want to make sure it's person-centered and not facility for the facility's convenience, but person-centered approach. And it's systematic, and the staff are trained, so that we don't have any staff opening the front door, no mask on, no, not checking people in, not giving them the census, not giving them the staff roster, and not inviting them to please have a seat. You'll be with them in a couple of minutes to get anything else they need. And then again, practice with your staff on passing meds, because this is one of their big focal points, is they're watching the whole QMAP process. All right, complaint responses, okay? If you cannot accommodate a visit, something went wrong and you cannot allow a visit for that particular day, make sure that you have signage on the front door saying all indoor visits have been suspended for today. You don't have to say why. And then you can send an email out, in a family email if you wish, and say indoor visits were suspended for today. Please check your email in the morning for further information. You don't need to educate or say why you suspended visits. If you're in an outbreak, your signage should read, we are currently experiencing an outbreak. We are on a no visitors allowed. Please call and we will arrange a televisit with you, and so that you may visit your loved one. And so you can do phone, you can do tablet, you can do iPads, you can do laptops, whatever you're doing to have your telehealth visits, okay? This is a list of stuff that I have been dealing with in POCs and helping the community for the last 30 days. And these are the 5 top ones. Staff not wearing their mask correctly. Staff reporting they're not trained. Residents confused and don't understand. General infection control issues. Lack of signage. Lack of where to put dirty things, how to do laundry, especially if it's contaminated, not having easy on the door in the laundry room a reminder, how, if this laundry's been contaminated, do the following steps, use the following products, disinfectant products, rinse, and then a wash cycle in hot water. So again, remember, especially with this diarrhea explosion that's happening right now, norovirus and C. diff only get out of linen and hot water. The nasty part about that, it ruins the color of everything. And then if you use a Clorox product, remember it's got to be under lock and key. It cannot just be sitting in the laundry room. So again, you got to have very specific instructions, really clear, and post it inside the door in the laundry room for staff to review so they don't have to remember it. And then the most common tag that I help people with is everything that's wrong is the administrator's fault. And that's literally what I call it. And so we've been dealing with that, and it really agitates the industry a lot. So next steps. We're going to continue to help and coach. As I said before, I look for best practices. I look for things that'll make your life easier. You get them in place, you've got it. Then all you got to do is hang on and do it. And so I continue, because I have more time than you do, to do everything I can to put some order to all this for you. And then our agency is committed to the industry, and we'll continue our assisted living classes. We'll continue these monthly discussion points. We'll continue our QMP discussion points, and until we're no longer needed, I think. Okay. So I do want to close this with something that came to my attention that I did not know existed. And you may be aware of this already and just ahead of me, and it may be new to you. So they're called critical incident reports. Because you hold a license under the state of Colorado, this guidelines is for you as well as for any, no matter how people pay. It doesn't matter whether they're private pay or not, okay? All right. So if your building has Medicaid beds, you've applied in your licensure, you ask for 3 Medicaid beds, or you have PACE beds, you still have to use these CIRs, but you need them in general because you also, if you have a critical incident, you have to let the ombudsman know and possibly APS. And then if you have somebody under HCBS in your facility, under a waiver, mental health or elderly, blind and disabled waiver, and you know it is Medicaid, then you have a relationship with a case manager at the single entry point, and there's 7 in the state. So you need to know who that is, who your case manager is, and you have to submit it to them. They review it. They may ask you for some clarifying questions, and then they let Cheryl know that they got it and reviewed. So I went through this in a rural agency. Like I said, I had no clue this thing was existing. And so we had to do some fast catch up. In this case, it remains a mess. And we're having some major struggle with adult protective services in this rural area, because they're trying to protect the resident, say this resident has to stay at the facility, and this resident is super high risk, has committed some felony against another senior in the building, possibly sexual felony against another one in the building. So, we're just trying to move this person on. And APS doesn't want to deal with it because apparently they dealt with it in the past, but weren't straight, didn't tell the building about it. And so they're trying like everything to keep us from evicting this guy. But we met early this morning, and I think we'll be fine on the eviction. If you have hospice or PACE, make sure that they get a copy of this CIR. Now, the cool thing about this incident report, you can use it as your standard incident report. You don't need to do 2 incident reports, just use this one. It will work for everything you guys do. And then in your QMP notebook, which I'll be tackling later this month, is that you will be tracking and trending basic things. One of them is complaints, and one of them is going to be CIRs. And then who did they give them to? So when I have the meeting later this month, I will give you a tool for your QMP book that I've figured out finally. All right, so if you file a critical incident report, more than likely you also have to file an occurrence report in the portal. And it has 2 parts. So when you do an occurrence report, you type in what you know. Then you go back and it'll say investigation and final results, and there's an edit button. And I go in every day or a couple of days as I get more information. I just keep editing, adding additional information. What I'm doing on this particular CIR, because it is such a disaster, is I've been also emailing Cheryl and the head of state of the Ombudsman, the head of state of APS, the head of HICPUF. I've been engaging all the higher ups because I want them to know that this process should be clean and easy, and instead their employees are making my life nuts. And I've been very verbal and very loud about it. But that's my methodology, and there's a purpose in that. You don't need to do that, but you do need to make sure that everybody has it. When you send it, please on Outlook, use your encrypted email. So you can buy an encrypted email service with your carrier for your emails, and make sure it goes encrypted. And then you send a copy to yourself for signature. You keep that in a file. So when it comes back, it automatically goes in your critical incident report file. And then you've got a log of everybody you send it to, because you don't, and when they get it, when they open it, it comes back and says open. And when they read it, it comes back read. And then you have validation, and they can't say, oh, we never got that. And again, we're having trouble with single entry points, and a couple of them, because their software is got these firewalls in, and sometimes this stuff's going to scam, and the employees don't even know that it's sitting over there. So again, protect you. This is important for your company. So encrypted email, read and open and read, check those boxes, and a copy to yourself, and then you covered your bases. If you need help with an occurrence report, for God's sakes, pick up the phone. You know it's okay. We'll help you. Eileen knows how to do them. I know how to do them. And we will walk you through and make sure that you are comfortable, because we want you to use this tool so that you've got it. And you should have the occurrence manual on your desk. And again, you can use the Control F function, go through it and find what you need. So we had, again, in the state employee saying, well, you haven't filed any occurrence reports on verbal abuse. Well, you can't file an occurrence report on verbal abuse unless it melds into other topics. And so I just send that over to her and say, again, you don't know the policies. And again, you are not following the regulations, and send it to her boss at state and saying your APS workers need to be retrained on how this all works. So I haven't heard back from her yet. But like I said, I've been on a tyrant on this whole thing because it is such a sticky mess. So let's look at the process of a critical incident report. First, you identify a situation that something went bad. So somebody got hurt, somebody fell and had an injury, 2 residents got into a fight and there was damage, got a bruise, got a cut, somebody fell down. Again, you know, somebody eloped and you couldn't find them in 15 minutes. These all are examples of critical incident reports, okay? You want to investigate, and this is one of the sightings I see, is people say, well, I investigated. Well, not if you didn't fill out the report correctly. So your investigation just went in the trash. You might have done it, but you're going to get no credit. And make any urgent change to care plans, communication, okay? So if you have resident-to-resident abuse, they want you to call the police. I can guarantee you the police department's not going to be happy with you. And what I say to them, I call the non-emergent number and say, I'm only doing this because I'm required as a mandatory reporter to let you know that these 2 residents slapped each other in the facility, and we were able to immediately separate them into different areas, calm them down, and there was nothing else happened. We have filed a report at CDPHE and we're notifying you. Then you fill out this critical incident report, you send it over to APS, you send it over to the case manager, and you've done due diligence, okay? Then you want to go back in on the portal, make sure you do that finished investigation. And what I would recommend is assess the care plan, look at your policies and training. Do you got anything you need to do? And if you need to, get it on the calendar or do it quickly, even if it's just a hudding coaching moment with a particular group of staff. Like you're looking at, let's say you're having most of your problems in the day are starting like 4 or 5 in the afternoon to 7 or 8 at night. And this is when things are really hard. And you may change your staffing and have more staffing in that time frame and lighter staffing after 8. Every facility is going to be a little different, but this process is circular. So it allows you to identify a situation all the way up to any changes you made, and they may be very minor. Just, you know, you put in a care plan, please make sure that George and Edward are not supervised and alone because they get into altercations. And so we put that in some sort of communication tool so that the staff are aware and try to mitigate that before it becomes a problem. So this process is not hard. It's just capturing back what you already do and put it in writing. All right, so here's some areas that could create a critical incident report. Sudden death, okay, fall with injury, elopement with a lost client more than 15 minutes. Those are some topics that could easily do it, okay, along with elder abuse. So I am going to stop here, go to the chat room and make sure we've got all the chats. Okay. Okay, so Chrissy, as much as we can convince them it will not hurt anything, we can't require them. We are going to encourage them. I won't be sending the recording out that I know about, but I may be wrong because we are recording it. And then Eileen has a way to send anything I want to send out to everybody that's attended. So yeah, I will see if we can send the recording out. Yes, so it's May the 31st, Stacy. The report is in the portal. There's a flu portal. So when we talk Monday or next week, Stacy, get with me and I'll help you get to that flu portal so you can get that in. We had some trouble with signing on to the dang thing, and we had to get Chris's help down there to correct because they put what they knew and there was email changes. and there were sign-on changes, and those didn't filter over to the Flu portal. So that's some of the stuff that I've seen. Okay. So a portal is a communication tool from your facility to the state. So Stacy, if you don't have access to the portal, whoever manages the portal needs to put you as a managing editor, and that'll